of the Adult Survivors of Child Abuse, or ASCA, and also he serves as the medical director of Bellwood Health Center in Bellflower, California. He specializes in the treatment of abused children, adults, and codependents, as well as multi-generational family dysfunctions. Dr. Nair, in his past work, has challenged many of the assumptions and the misdiagnosis and mistreatment of these populations. He is the author of the book, A Step-by-Step Guide to Recovery. Would you please welcome Dr. Mohan Nair. Mohan, welcome.
Dan? Yeah. Oh. There is, could you tell Jenny to go up to my room, and there's a few slides that overheads that I forgot. It's on dual diagnosis, and it says, the folder says, this conference, Colorado, and it says misconceptions and misdiagnosis. It's in my room. She should find it. Good morning. Good morning. Got lots of water, so I always tend to get dry-mouthed, especially talking in front of large audiences. It's once I get going, I'm okay. So bear with me. Yeah. I wanted to get a sense of the audience, not having been here the last couple of days, and so I just wanted to go through. This is primarily a conference on addiction, so my sense is many of you must be from the addictions field. Yeah. Mm-hmm. Yeah. How many people are chemical dependency counselors? Oh, a lot. And what about like marriage family counselors, social workers, PhDs, MDs, psychiatrists? No? Okay. Well, no, I can talk about them. How many of you are from the clergy? Okay. And the military? Okay. Okay. Well, I hope that the next hour, I'm going to be talking about some things in general, because it's an hour-long talk, and I really have to be general. But I will be talking more specifically about the elements of treatment of dual diagnosis and things like that this afternoon in my two workshops later today. Specific things about treatment. But I have to say that my background is in working with trauma, and really working with psychological trauma. Before that, I did surgery, and I was primarily interested in doing trauma surgery. And I kind of felt back in '77, I had to make a choice in terms of where should I move geographically. And I was thinking at the time of joining the military and continuing surgery. And I decided to go to California. And I said, 5 o'clock in the morning drills and 36-hour shifts versus hot tubs, etc. And it was a hard choice, but no, just kidding. No, but I worked in trauma, and where I got very involved in working with trauma was working with the VA. And unlike most of you, I came to this country because I made a choice, because more than any other place in this world, I believed that America was where the power of one, the fact that one person, an individual, could make a difference was very obvious. The whole world saw that in America the power of one was very evident. And I also believed it to be a place where the sense of individual freedom was preserved at all costs, and that when you when you believe in freedom, then you always live with the knowledge that you have to shed blood, your blood and others' blood. And I come from a background where we fought as soldiers for the king for thousands of years. And in return, we got land grants for them. And we have a lot of military people in my family. And for me to come to the VA and see the kind of things that went on, it just hurt me terribly. I could not believe the way America treated its fighting men in the years that I worked at the VA. It agonized me because I related to a lot of what they went through. And to see what was happening at the time to the veterans really shocked me. And that is where I started working with trauma. And seeing how trauma caused so many problems in people that were later misdiagnosed and mistreated. I mean, I'd see people that came with boxes of medications, their hands trembling. We would have lists of veterans that in our emergency rooms, that the moment they came, we were basically told them to transport them to state hospitals, to medicate them, to call in the police. And I wrote a paper about how this was done in almost an organized manner, this labeling of veterans, this labeling and the misdiagnosis of traumatic conditions. So ever since then, I have gotten deeper and deeper into the whole issue of trauma. And later in the afternoon, we can talk a little bit more about the specifics of what is trauma, and how does trauma cause all these problems, and what is its connections to psychiatric illnesses and addictions. I think the theme of this conference, I think that most of you have some degree of awareness about that, about trauma and its consequences, but I'm going to get more specific about it. In the meantime, how does this all connect to mental health and the topic that I'm going to be talking about? Well, more than anything else, trauma causes a loss of balance. And it's this loss of balance that often causes, that is at the root of addictive illnesses and so-called mental illnesses, psychiatric illnesses. I brought my DSM-3, my Bible, not. Okay. Because ultimately this is just a book for labeling. It is used by practitioners for writing to insurance companies, but it doesn't tell anything about what's really going on with the person. Okay, and it's a phenomenologic thing. You just describe what's going on and you give a label. I am kind of perturbed over the last few years about a trend that I have seen in among chemical dependency counselors. And there are two books, for example. One of them is published by the Guilford Press, and the other is from Hazelden. And it's on the issue of dual diagnosis. And the sense is that there is a thing called dual diagnosis, and all these people really suffer from not just addictions, but they have an underlying psychiatric illnesses, a psychiatric illness, a major psychiatric illness, or an access to diagnosis. For example, 50% of people, 50 to 60% of people with alcohol and chemical dependency problem are described as thank you, are described as having antisocial personality disorder. I don't know if you've looked up antisocial personality disorder. I don't want to go into it at length right now, but it basically means a person that is remorseless, has no conscience, has no capacity to love, is completely self-centered, does not learn from mistakes. And when I see all these people that I have treated, the alcoholics and chemical dependency people I have treated, and for them to walk around with the label of antisocial personality disorder is for me not to see the heroism that they have shown in being able to wake up every day and live in this world in spite of the things that they have gone through. And when we label these people with these things, then we are not validating the courage the capacity for love that they have carried on in their hearts and their souls, and we just label them and we deny them care. I mean, in fact, one of the things you learn in psychiatry is that, especially if you're treating inpatient and things like that, is that if you put an access 2 diagnosis, then the idea is you don't want to treat them because access 2 diagnoses are things that are set in stone and you can't change them. Okay? You can't change them with quote unquote psychoanalysis. You can't, and you cannot change them very much with long-term therapy and things like that. And it's basically writing off people. And I think that's a terrible attitude. So, over the years, there has been like more and more of what I describe as orthodox psychiatric thinking, conservative psychiatric thinking, and a disease model of addictions coming into play, where more and more, I see more and more people that are in recovery also on medications. And I'm deeply concerned about that. Before we go on, I just wanted to bring you up to date with some of the contributions. Well, first of all, I wanted to show you a little poem. This is a poem by Anne Sexton, and she was a chemical dependent, among other things, a psychiatric patient. It's called The Addict by Anne Sexton. Sleepmonger, deathmonger, with capsules in my palm each night. Don't they know that I promised to die? I'm keeping in practice. I'm merely staying in shape. The pills are mother, but better. Every color and as good as sour balls. I'm on a diet from death. What a lay me down this is, with 2 pink, 2 orange, 2 green, 2 white midnights. Fee, fi, fo, fum. Now I'm bored, now I'm numb. And the essential component of having to hold back pain is a theme that we see all the time in addictions. Okay, so I'll get back to what I call psychiatry and the pharmaceutical industry's gifts to the field of addiction recovery. Today it's Prozac, but yesterday it was. The psychiatry and the pharmaceutical industry's gifts to the field of addiction recovery. In 1898, a new drug that was safe, non-addictive, was introduced as a cure for, instead of giving morphine to soldiers, they felt they want to give something safer and better. It performed so heroically, it was called heroin. And cocaine was a big, Freud was a big advocate of using cocaine for treating conditions and tried it himself. Insulin coma therapy, including for the dancer Nijinsky, who was one of the people that was treated for alcoholism with insulin coma therapy. And these are procedures that at times would have up to 12%, over long periods of time, they would have morbidity and mortality up to 12%. They used to be used extensively in VA hospitals. When I was in medical school, we used insulin coma therapy all the time. And we're talking about 1970s. Okay? I still see lots of patients that have had insulin coma therapy. Electroconvulsive therapy for anorexia nervosa and eating disorders. LSD for the treatment of alcoholism. Lobotomy for anorexia nervosa. I wrote down SA, which is sexual addiction, as in paraphilic disorders. And self-mutilation. Cingulotomy, it's a neurosurgery procedure. This is from 1984. A report at the International Conference on Treating Cocaine Addiction came up here. They had been successful in treating cocaine addicts by removing a part of their brain. It worked. Castration and the use of Depo-Provera, which is a chemical castration for sexual addictions and paraphilic disorders. You know, all sexual addictions may be paraphilic or non-paraphilic. When I say paraphilic, I'm talking about what is not normally accepted, dehumanized ways of dealing with sexual feelings, like pedophilia. I mean, you have extremes of things like like lust, murder, and things like that. And then the more common paraphilias like exhibitionism and things like that, which are not acceptable in society. Thorazine for anorexia nervosa, Valium for alcoholism in 1960. Almost every psychotropic medication has been touted as being useful for the treatment of addiction. Yesterday it was Haldol, today it's Prozac. Okay. So this is one of the situations where you want to look the gift horse in the mouth. Okay. There is also an effort on the part of psychiatry and mainstream medicine to what I describe as pathologizing recovery. In the 1800s, the Quakers established a humane system to care for the mentally ill. Then the doctors moved in. Is it a coincidence that as a grassroots, internally motivated recovery movement becomes increasingly successful, as with inner child work, trauma-specific groups like ACA, all of these things, ACA, NA, and incest survivor groups, sexual trauma groups, and stage 2 recovery concepts come about, where people recognize that there is a deeper level of wounding that needs to be treated there. And we have the men's movement, we have the women's movement, and as they're beginning to draw people that traditionally were seen as mentally ill, which means 15 years back you wouldn't see a person that has ACA problems going to AA meetings, but we see more and more people that were traditionally seen as being borderline depressed, going to meetings like this and getting better. Okay? And that psychiatry should come in with a new understanding and a fresh bag of quick fix goodies. By medicating up to 70% with mood-altering substances, psychiatry prevents people from exploring their wounding, understanding their pain, and doing the work of spiritual recovery. Okay. And I've written down a little bit, which I'll talk about more this afternoon, that the dual diagnosis experts warn against dredging, as in bringing up painful material, the kind of thing that's done in 12-step work, the whole idea of inventory taking. I want this to be, I'm going to leave about maybe 10-15 minutes for questions, okay? So, however, if there are things that I'm talking about that you just can't bear to hear, then, or disagree with strongly, please, let me know and I can address them right away. Or you can write them down and we can talk about it at the end of the talk. Okay, the misconceptions. One is the need for awareness. There isn't enough awareness in people about what is going on with their quote-unquote illnesses, what is going on with psychiatry, what is too much. Again, we are talking about a population that traditionally has looked outside. Okay, part of being wounded in childhood, coming from ACA backgrounds, coming from backgrounds that have either been neglectful or abusive or discounting in some manner, is one looks for answers outside of one all the time. And there is a tendency to, there's decreased self-awareness and a tendency to look towards the outside for answers all the time. And one is the need for awareness. And psychiatric concepts, a lot of them are based on that there are genetic problems, that there are brain chemicals, and that the cure comes in things like medications and electroconvulsive therapy, which if you are not aware of, I need to tell you, there is more than 100-fold increase in the last 4 years in the use of electroconvulsive therapy. Every weekend, there are workshops that are being held all over this country where 30, 40, 50, 200 psychiatrists go and get trained, who have never given ECT before, go and get trained. The insurance reimbursement is very good. In fact, what is different now from before is that if you have a patient in treatment and you've tried one kind of medication and it doesn't work, in the old days, you had more time to try another kind of medication. But now the emphasis is that if they're not recovering with medications within a reasonable period of time, which keeps shrinking, then I'm asked, why don't you give them ECTs? Okay? I read this in one of the journals, a heading. Dissociative disorders respond to electroconvulsive therapy. I mean, so does a big blow on the head. You know? So, and there is a very sinister side, and I wrote down the offshore. And for those of you that are interested, I can have this sent. If you will put down your names and your address, I'll be glad to send it to you. But this is a case that was written up in the April 1990 issue of the American Journal of Psychiatry, and it's written by Dr. Gerald Klerman, who has written several books on depression. And Gerald Klerman's, the issue is that, the gist is that people that have major psychiatric illnesses, like major depression, anxiety disorders, all of these things, need to be treated with medications. And if you're not treating people with medications, then you are liable for malpractice. If any of you are treating people and are, quote-unquote, withholding the right treatment, which is medications, then if your patient kills themselves, then you are guilty of malpractice. Okay? When you look at it, all major psychiatric illnesses, whether you're talking about attention deficit disorder with hyperactivity, obsessive compulsive disorder, major depression, psychotic disorders, all of these have medications. Okay? Judith Rappaport, who has written The Child That Couldn't Stop Washing His Hands, I listened to her about 2 years back at a conference put together by the NIMH, and she feels that attention problems, hair pulling, nail biting, all of these things are part of an obsessive syndrome and need to be treated with anafranil, a very, very toxic kind of drug. Fred Goodwin thinks that only 1 out of 10 addicts are medicated, and 9/10 of them should be medicated. So there are literally, imagine the number of addicts. So the idea is that there are a lot of unmedicated addicts that are walking around that really need to be on Prozac, Thorazine, Melril, lithium, or one of these drugs. This is the pitch. And he was the chief of NIMH in the area of drug and alcohol abuse. Okay? Frederick Goodwin. And so you have a situation where 7% of the mental health delivery force, which is what psychiatrists are, dictating to 93% of you that have gone through your experiences in life, to school, gotten degrees, that everything that you're doing is invalid, that all this group and biofeedback and gestalt and inner child work and individual therapy is all BS. It invalidates your education, okay? It invalidates your life experience and basically says you can treat things that are not billable, but anything that is billable needs to be treated with medications. Okay? I think that there is, and that is what I mean by there is a need for awareness. I'd be glad to send you the article. Okay. Psychiatry perverts the findings of neuroscience for self-gain. Theories of chemical imbalance, like, for example, serotonin abnormality. Today it's serotonin. 15 years back it was norepinephrine. The truth is we don't know. Okay? We don't know. It is like the blind man and the elephant. Okay? I mean, certainly mind and body work in union, and the environment work in union. Your chemistry when you go into an interview is different when you're playing on the beach with your wife and children, or with your husband and children, or with your boyfriend or girlfriend, or you're in a meditative state. You know? Your chemistry is different, but finding different chemistry doesn't mean that you need to move in with chemicals. And this is the big pitch that psychiatry often makes, is just because you find chemical abnormalities, then you need to be treating with medications. I mean, several years ago there was a report from UCLA, for example, that there were certain changes in the frontal lobe in obsessive compulsive disorder, and at that time everybody was gung-ho, but let's put everybody on anafranil. They're washing their hands too much, or they're thinking the same thought too much. Now 3 years down the line, the finding is that people that were behaviorally treated or treated with medications both showed the kind of improvement in brain functioning in this imaging thing equally. So the thing is, one doesn't have to use medications to have to change states of mind. And states of mind are part of things that we have control of over time. So there is a lot of things that are being sold. I mean, I constantly hear people saying that my psychiatrist told me that I have a chemical imbalance, or this lithium is to treat my chemical imbalance. There is not a single book in psychiatry that says that people need lithium. Okay? There is not I mean, it is not as if when you have a deficiency of vitamin B6, okay, or thiamine, you come to a point where you can't think straight, you start getting fuzzy, you have an organic brain syndrome, you find it in people with anorexia, you find it in people that have a lot of alcoholism. But there isn't that kind of lack of lithium. You don't find measurable amounts of lithium in everybody's body that you have to give maybe 10,000 or 100,000 or 1,000,000 times as much lithium that is present as a trace element. I mean, the earliest data on lithium was by giving guinea pigs large amounts of lithium, and they got wasted, as in not dead, but flattened out. And they figured if they gave it to somebody that was talking fast and moving too fast, he'd get slowed down too. But it isn't as if you have too little lithium. And a lot of psychiatrists will tell people that that's the case when it's not the case. Okay? And there is a tendency among all physicians, in a sense, to infantilize patients as if they are not to know these things. And part of what we have to teach patients and people is to be accountable for things, not to take everything for granted. And I wrote down the OCD and the PET findings. Anyway, psychiatric diagnosis such as major depression is not the same as things when we talk about pneumococcal pneumonia. What we are talking about being able to, we're talking about when you talk about pneumococcal pneumonia, we're talking about a certain organism that infects a part of the body, the lungs, the lungs. And we can see it in the slide. When we talk about major depression, it is the same as you and I saying, as my patients come and tell me, Doc, I'm majorly depressed. And they're telling me the same thing as another expert who puts a little note and says he has major depression. Because major depression means you're very, very depressed. It doesn't mean more. It doesn't mean less. It doesn't say where it's coming from. Okay? And a lot of times psychiatrists will give these diagnoses as if they have an exact understanding, like pneumococcal pneumonia. There is a tendency to what I call classifying and controlling. Labeling with personality diagnosis, which I think is very toxic. For example, that antisocial personality basically means that a person is remorseless and cannot learn from education. Borderline personality is basically flakiness, and these are all people, lots of women and men have these kind of problems. Okay. Abuses, psychiatry abuses by not pointing to the inner strengths that a person has, and it undermines the accountability that people have, that people need to have. Psychiatry in the third party pairs, drug companies mandate a drug treatment with rigged up proof. And there are lots and lots of studies of this. There is what I call the 80% rule. Back in the turn of the century, in the 1920s, to one of the New Jersey state hospitals, I believe it's Dr. Cotton, he would just remove organs from the bodies of people that had mental illness. It started out with the teeth, the thyroid, then the stomach, and down to the uterus. The uterus was one of the first ones that'd be taken out, because they figured if you take out the uterus, everything's going to be okay. But he said that he had 80% recovery, and it's the same thing through all of these. In the 70s, I heard imipramine is helpful in 80% of the people in treating depression, anxiety, and panic disorder. In 1992, I hear the same thing about Prozac. Okay, and I wrote down the drug cartel. I'm talking about the pharmaceutical companies. Okay. The top 30 companies, most of which are outside the United States, many of them are outside the United States, okay? The top 30 pharmaceutical companies individually earn more than 2/3 of the nations in the world combined. Okay? Yeah. I'll say it again. The top 30 pharmaceutical companies individually earn more money than what 2/3 of the nations have earned in a year. 2/3 of the nations in the world combined earn through a year. 14% of the people in the world are on 50 billion people in this world are on psychotropic medications. 14% of people in this world are on psychotropic medications. There's 30 Valiums to every person in this world. 1,500 million dollars are spent on advertising, and the average MD, $5,000 are spent by pharmaceutical doctor, every doctor in this country. That's some clout. So my question is, I call this the dangerous myth of dual diagnosis. The backdoor men. Will chemical dependency counselors be carrying Prozac pens? Okay. Okay. Dangerous bedfellows, psychiatry and the drug cartel. The redefining of addictive illness as in shifting the locus of power from oneself and from self-help groups to outside things like illnesses and medications. The new gurus, addictionologists. And addictionologists, I mean, I tell people when they come and work in chemical dependence, you've got to forget everything you've learned in psychiatry, because you really learn nothing about recovery in psychiatry. And then you have a 3 or 4 year scholarship, I mean a residency above that tells you how to become an addictionologist, how to give even more medications to people that are addicts. Okay? And I wrote down that it's Dr. Bill versus Dr. Frank. I mean Frankenstein. Okay? Because psychiatric medications deform people. When you give medications like Thorazine, Haldol, Melloral, Stelazine, all these what we call major tranquilizers, there is a risk. When you take these medications for over 3 months, any of these, you have the potential to develop tardive dyskinesia. Tardive dyskinesia is a permanent neurologic problem. Okay? In some people, in the older age group, over 60% of people will get tardive dyskinesia. I mean, I see people that used to have addiction problems or some kind of depression problems, like in the 50s and 60s, that are now married, have children, grandchildren, and I ask them to open their mouths, they're nicely dressed and, all of these things, and there's this movement of their tongue that tells me they've got tardive dyskinesia from the Melloral or Thorazine or Stelazine that they took 20 years ago. It doesn't go away. Okay? I'll talk more about it later this afternoon, but so you have movement disorder. When you see people in psychiatric hospitals, when they walk around like this, it's not them, it's the medications. And that's what I meant by Dr. Bill and Dr. Frankenstein. Okay? When you get away from the principles of self-healing, then you put yourself in danger, including the danger of long-term brain injury. A lot of the dual diagnosis programs, I mean, if you look in this book that's come out by Guilford Press, you will see that most dual diagnosis programs don't have people attending 12-step meetings. 100% of them give medications. And there is very little attendance of AA and NA, and as I said earlier, there is none of them that insist on 12-step meetings. Dual diagnosis victimizes because it puts down that 70% of men and 85% of women that have addictions have this quote-unquote anxiety disorder, which might be genetic, all of these things. When I believe that anxiety comes about because you don't know how to handle life, because you've never learned how, because it was not, the essence of self-soothing was not learned in infancy and childhood, not acquired, and these are things that need to be learned instead of taking medications. AD is affective disorder, as in mood problems. Anxiety disorder is 13 to 25%. On the left side is men, on the right side is women. Schizophrenia in 1 to 2% of people with addiction problems. Antisocial personality disorder, 30 to 60%. Schizotypal, 9%, 8%. Other psychiatric, to 10%. The genetics of addiction. Okay, then there is this thing that, which a lot of time when I give a talk like this, they're very happy to hear. So how many of you think that addictions are inherited? And there's all these hands going up. And then I ask them, would you consider not having your son or daughter marry somebody because they came from a family of alcoholics, in the same way that you would look at them if they had some kind of blood clotting problem, or if they had something like Huntington's disease? The truth is, we don't know about these things. Okay, we are told all the time that it's genetic. The thing is, there is certainly a case for genetic loading, but it's not. When we talk about the genetics of addictions and mental illness, it's not like we talk about Huntington's chorea or other kind of things like Down syndrome. There isn't a specific gene, okay? There isn't a specific gene that says that such a person is going to be prone to alcoholism. The kind of findings are that people that are prone to depression, people that are prone to self-destructive behavior, recklessness, all of these people seem to have certain chemical findings. You know, it's very, very general. Okay. The question is, what is inherited and what is not? We don't know. And to say you inherited this alcohol gene, you messed up, you just got to carry this load and you're going to pass it on to your children, that is a very unempowering message to give to people. And I mean, there are things, is it serotonin, is it endorphins, is it dopamine problems, too much, too little, morphine-like substances? There's all kind of things, broken lymphocytes, chromosomes, all of this suggesting, but there is no hard data. And in a sense, bad science, this is bad science, and it kind of causes psychiatry takes on a lot of this bad science and tries to sell it as something that's real. And the sinister side is that lithium is not a nutritional agent. Okay, it's not. It's not. You don't take lithium like you take vitamin B6. It'll kill you. Okay, it'll kill you. There are over 4,000 deaths in this country every year when people combine lithium on hot days. When you're on lithium and you wind up in the hospital and they strap you down and then they give you thorazine, it tends to cause what's called neuroleptic malignant syndrome. There are 4,000 deaths in this country. People that go into hospitals because they hallucinate, or because they start yelling and the cops come and they're found to be manic depressive and they're taken to hospitals that wind up dying from these medications. Okay, that's what I mean, the sinister side. And then ignoring the whole issue of post-traumatic stress disorder and disorders of extreme stress. Okay. And I'm going to kind of briefly talk about some of the direction that we need to take in terms of getting these things better. And I know that I'm talking about things that a lot of you may have had some discomfort. It's very different from what you might have heard. I got to say that when we talk about recovery, it starts with childhood or even before. And I'm going to talk some more about the specifics of how it directly connects to healing, like body work, like 12-step work, like spiritual recovery, all of these things. And we must move away from the premise of looking at these as inherited biologic conditions. Dual diagnosis, addiction is a spiritual crisis, an attempt to fill the sacred emptiness that we have within people, this lack of love or whatever we are not having in terms of being fulfilled. That addictions arise and continue from an inability to love and be loved, to celebrate life and celebrate the spiritual, that real recovery can only come with our man-made wounds and getting away from soul-destroying relationship, jobs, and other dangerous pursuits. Oh, okay. I'm sorry. Can I take it off now? Okay. Well, you know, I'll tell you what. I mean, I was going to have these. I will make copies of these and send it to you if you would like me to. That might be easier, and that'll give you time for questions. Why don't I just do that? Okay. What's that? Okay. I'll be there. Yeah. Okay. But those that are interested in getting transcripts of this, I'd be glad to send it to you. Okay. I just want you to focus on the last part, and this is really what I am talking about, the treatment side. Okay. Getting from a state of either mental illness, quote unquote, or addictions to becoming balanced in life. First of all, I mean, there has to be accountability. A couple of weeks back, there was a thing about 5 people that were involved in the mall murders, and they've decided that the ringleaders should get the capital sentence, but the other 4, because they were kind of led into this by ringleaders and because they had a long history of child abuse, should have more tempered sentences and were given life. The thing is, we are all accountable for the things that we do in life, okay? Action and inaction. For every person that does something wrong, the most dangerous aspect are the people that follow. For every leader, there are 10 million people, 1,000 times more people that are willing to do. It is the inaction of many. It is not sins of commission that are dangerous as the sins of omission. And that is where the lack of accountability comes in, that people don't take charge, that they don't, it's words and not deeds. It's not making things happen in their lives. And people have to be accountable. We can never go into a second generation slapping children around with the excuse that we were slapped around, or drinking and being drunk and not being able to show passion and compassion because we have to suffer this wound. The wound is not it was something that was given to us, but we have to be able to get beyond that, and that's the message. That's the message we need to give people all the time. It's not like if you don't have the right kind of insurance, you're not going to get better. The thing is, I tell people all the time, you have to assume that you have no insurance, and recovery depends upon you. You're very fortunate when you have insurance, but because you don't have insurance doesn't mean you should not recover. Getting better from addictions and mental illness is something that a person has to take on themselves. And as I said, no one wakes up with blood on their hands. There is a long series of things that are done or not done. When a woman beats her husband to death while he is sleeping and then goes to court for that, there is a long list of things that she has not done for the last 20 or 30 years that she should have done, for which she's accountable, and we must hold her accountable, just like those 4 men that are getting away after having killed children and grown people in cold blood. Okay? That there has to be accountability at all levels, including the need to bring joy into one's life. That to see action and to look at muscles at the cutting edge of the will, because all thought doesn't make any sense as long as it is not translated into making changes. So the behavioral is very, very important. You can read all the 12-step books, but if you can't make it to the meetings, you're not making any changes. Okay. Becoming aware of disrupted consciousness, such as by denials, dissociations, addictions, acting out in physical illnesses. For example, in our program, we stopped giving any medications, including medications like antacids and things like and Tylenol, because we felt that in people that come from a background of trauma, every physical symptom is a cry for help. It's a feeling. And if you medicate that, then you don't help them make that connection. When your feelings have been denied, then you cannot then the only thing that comes out is physical pain and complaints. And the way in which you get connected is to help people, push people in that direction, as opposed to just giving them more medications. To do memory work, I call it testimony. Testimony is speaking out one's truth, and that is the most important thing. Most important part of trauma work is to be able to speak about one's pain. Testimony in healing, the mobilization of male and female energies, body work, holding, massage, exercise, sexual healing, and confrontation when it's appropriate. And then the spiritual, finding meaning in trauma, going from not being wanting to involve with people to finding closeness and feeling good in the companionship and being with people and being connected. Because, I mean, that is the most important thing. We have gone from talking about codependency and all of these things, but the most important things in our lives are what we get from each other. You know, you may have the most beautiful house and the most beautiful scenery, but if you do not have a person or people to relate with, then it is all empty. To find love, creativity, and passion. When people do not find love, creativity, and passion, they become sick. Unlike animals, the largest part of our brain has to do with love, creativity, and passion. And when we do not exercise that part of our brain, then we become physically and emotionally sick. I'm going to put this, and Dee Dee is someone that I know. I want to tell a story, but I'm not going to right now. Maybe I will later this afternoon. I think there is a great, I'm always moved by what she told me. But she is what I call a triumphant personality, one that got beyond addictions. She was addicted to alcohol and drugs for a long time. The triumphant personality is an individual who has suffered overwhelming, excruciating, and catastrophic experiences. Stronger, more creative, and more loving. Such a person may be expected to be at the highest risk to suffer the symptoms of PTSD, to suffer stress-related illness, to despair and die, or at the very least, to be creatively impaired. But instead, the wounding becomes an enhancement to them, an opportunity for growth, success, and joy. I'm going to stop now. if I started late, Dan would give me a few more minutes.
How long does it take to tell Dee Dee's story?
2 minutes? Okay. Well, this is a lady that I met. She's not a patient, but she had severe drug and alcohol problems for many years, through her teens, through her early 20s. And then in her 20s, in her mid-20s, she got cancer of the skin. Okay, and she was very devastated. And at that point in time, she started painting. She started painting a lot. She would paint these. Her painting theme would be these Dalmatians, dogs with black spots on them, the representation of the melanoma. And then over time, her painting, she began to paint. Her memories came back. And what she found out was that she had been incested. She had completely blotted out the memory of her father incesting her. Okay? He had raped her from the time she was 5 years old until she was about her puberty. And she had complete lack of knowledge of that. And it was this trauma, this pain and shame, and all of these things that kind of drove her into an addictive pattern. And she always thinks about her, and she's completely recovered from the melanoma. I mean, it's been over 7 years. And she is very involved in all the recovery work. But she always looks on the coming of a melanoma as something that was very positive in her life, because it gave a chance for recovery. And I think about addictions ultimately as a way in which people will be able to get stronger and more joyful in life, as opposed to being less than, somebody to walk around in a crippled manner. Yes. Yes.
I have a question about psychiatry and your place in the field.
Okay.
You're a psychiatrist, right?
Yes, I'm a psychiatrist.
Well, what I want to ask you is how much resistance and trouble you find in your own profession. And I heard what you said about using these new elements in your work, in your treatment program, in the hospital. I use many of them in my own outpatient practice. But I want to ask you about the system, and for instance, the diagnostic manual, and some of the really thorny things you brought up, and how to change. What I do is I practice what you're talking about and just sort of know that the rest is a joke. But I have to believe that maybe you encounter.
The question is how.
To change
the question is how do we take some things on to the mainstream psychiatry? Well, I would say that I have less resistance now than I did, I'd say, 10 years back, because trauma is now validated a lot more than it used to be. Okay, so you have all these diagnoses, PTSD, which came on in DSM-3, and dissociative disorders. All of these things show the power of people talking and it being established. The power of the women's movement, all of these things making its impact. The power of child abuse. All of you may have read this child in New York City that wrote an essay about how she got raped and nobody picked it up. Well, in 1975, out of 2,000 complaints of child abuse, only 8 were filed by pediatricians. So people have to be staying on top to take it. This has to come from inside. So I think we have to, as citizens, as mental health professionals, we have to take responsibility for making sure that these things are noted as problems, rather than be pigeonholed into these kind of DSM-3 things that have been there before. And there is a lot of change. For example, I'll talk later this afternoon about whole categories of diagnoses that now go under, for example, borderline personality, antisocial personality, multiple personality, dissociative disorders. All of this will go under what's called disorders of extreme stress. So trauma is increasingly seen as a contributor for emotional and behavioral and addictive illness than it was before. And there is a major backlash. For example, you have a backlash against the 12 steps from orthodox medical field. You have this whole false memory syndrome society that has come into existence recently. And I'm not saying we should not have organizations that are cynical. I think that we always have to maintain a level of skepticism, and yet I don't think that a lot of their intentions are in the best direction. So yes, I think that we have to empower ourselves and voice the differences that we have, with orthodox psychiatry. I'd like to take a question on this side. Is there? Yes.
With the dual diagnosed, did I hear you say they shouldn't go to AA, NA, 12-step meetings?
No, you didn't hear from me that dual diagnosis shouldn't go for NAA meetings. You heard from me that they need to attend AA meetings, NA meetings above all else, and perhaps also ACA meetings and sexual trauma meetings, sexual addiction meetings, whatever is very specific to their problem. And that a lot of the most dual diagnosis programs don't push that.
I noticed.
Yeah.
That's where I work.
Yeah.
And another issue is
They don't insist on that, and I think that's the problem. They don't insist on them going, and they don't insist on them taking sponsors. I mean, to me, the key in going 12-step meetings is about taking sponsors. If you don't take sponsors, you kind of melt into the background. Dan, how much time do I have? Okay, 2 minutes.
I wanted to ask one other question.
Okay.
If we have females who have been sexually abused and they are on Psilocybin and they are delusional, maybe even addicted to the delusions, is it safe for them to be in therapy with a specialized therapist for sexual abuse?
Yeah. The question is, can people that have delusions and are on antipsychotic medications, can they do some of the specialized work of trauma? And my answer is yes. It is doing the specialized work of trauma that's going to help people get out of their delusions, at the same time making them accountable. The thing is, yes, there is a certain kind of convenience about being psychotic, that you don't have to deal with the world, and the world facilitates, society facilitates that role by the kind of enabling systems that we tend to give people. You know, it's not a win-win situation for either. You know? I'll take one more question and I'll stop. Yes? Could you repeat the question? The question is, do I not use lithium? Well, you know, my practice is very specialized. We get a lot of people that come to us for the largest number of people that we treat, for example, are mental health and chemical dependency counselors. And it's not because they have more problems. No, I think it's because they're more educated about what they need to work on. And so we see very few people with florid bipolar disorder. I'm not saying that it doesn't exist, but it is used very infrequently. And again, a lot has to do with if you're an unbalanced person, having a tendency towards chemical imbalance, then it is important that you begin to balance out your life and do things that help to enhance one's calmness and connectedness in life, including in work, sleep, all of those things. So the more stable a person becomes, the better their chemical imbalance is going to be corrected. So the emphasis, even with the bipolar disorder, is that you need to live healthy, addiction-free, abuse-free lives. Okay, I have to stop now, and thank you. My pleasure.